Good afternoon. I'm K Japhtha, and today we'll be discussing when delivery is overdue, which is a discussion on post-term pregnancy. For this topic, I was supervised by Dr. Ashley Moodley. The mean duration of normal pregnancy is 280 days or 40 weeks and 0 days. A pregnancy prolonged by more than 14 days, that is lasting 294 days or 42 weeks and 0 days or more, is defined by the World Health Organization and FIGO as post-term, prolonged, or post-mature pregnancy. These are the headlines we'll be touching on today. Timely onset of labor and delivery is an important determinant of perinatal outcome. Approximately 2% of all pregnancies dated by first trimester ultrasound extends beyond 42 weeks gestation. Most post-term pregnancies are likely a variant of normal and are associated with good outcomes. If a low-risk pregnancy extends beyond 42 weeks, the potential danger of placental insufficiency or fetal macrosomia arises. A known small absolute increase in fetal and maternal complications as pregnancy extends beyond its estimated due date. However, the optimum gestation for commencing formal antenatal fetal monitoring, example non-stress tests or biophysical profiles, and the optimum gestation for delivery versus expectant management has been a controversial topic. Gestational age is defined as the period calculated from the first day of the last normal menstrual period or dating by early ultrasound examination and is expressed in weeks and days. Early term pregnancy is between 37 weeks and 0 days to 38 weeks and 6 days. Full term pregnancy is 39 weeks and 0 days to 40 weeks and 6 days. Late term pregnancy is 41 weeks and 0 days to 41 weeks and 6 days. Post term pregnancy, which we are discussing today, is any gestation beyond 41 weeks and 6 days, or namely 42 weeks and beyond. Post-date pregnancy is a pregnancy extending beyond the expected date of delivery. More than 40% of women, and by the 40% of women we mean low-risk singleton pregnancies, deliver after the expected delivery date. In the USA, 0.33% and 6.25% of pregnancies are delivered beyond 42 and 41 weeks respectively. Zeitlin, Blondell, and Alexander et al. Describe the variation in birth rates extending beyond 42 weeks in 13 European countries, and they found that those birth rates ranged between 0.4 to 8.1%. In this study and other studies, factors that could affect prevalence include the accurate calculation of gestational age, that is early ultrasound done before 24 weeks versus a last normal menstrual period or menstrual dating alone, primigravidas who do shift the curve to the right as they do have a propensity to deliver after the expected date of delivery, and then things that shift the curve to the left, which be spontaneous preterm delivery, women with complications requiring preterm delivery or intervention, local practice patterns like planned elective cesarean section or induction of labor at 39 plus weeks. The etiology of late-term and post-term pregnancies have not yet been comprehensively investigated, and the cause is still largely unknown. Just factors that have been prevalent in literature is nulliparity, previous post-term pregnancy, obesity, deficiency in adrenal fetal cortisol, genetic components in certain ethnic groups, especially in the non-Hispanic Caucasian group, advanced maternal age, and male fetuses. With regards to a previous post-term pregnancy, the risk in a subsequent pregnancy is increased twofold. The diagnosis of post-term pregnancy is made on the clinician's most accurate estimation of the delivery date. Determination of the gestational age can be done using the first day of the sure last normal menstrual period, an early ultrasound done before 24 weeks, and a more objective practice would be the size of the uterus in the first half of pregnancy. The table below or attached is from the American College of Obstetricians and Gynecologists, or the ACOG committee opinion from 2017. And it basically looks at the early ultrasound and the discrepancy with the last normal menstrual period. And basically, if an ultrasound is done in the first trimester and compared to a last normal menstrual period, if it is within 7 days, the last normal menstrual period can be used. If it is a second trimester ultrasound and it is within 10 to 14 days of the last menstrual period, the last normal menstrual period could also possibly be used. When a patient has booked late and the gestational age is uncertain, the diagnosis of an uncertain postterm pregnancy should be made. This distinction is important as the management for this category of patient will differ. Postterm pregnancy is associated with maternal, fetal, and neonatal complications. These complications arise as a result of either ongoing placental function with excessive fetal growth or uteroplacental insufficiency resulting in fetal dysmaturity. The first of our complications we'll be discussing is macrosomia, which occurs when a longer duration of unimpaired placental function and ongoing intrauterine growth occurs, which then results in an unusually large fetus. The risk for birth weight greater than 4.49 kilograms is 3.5 times greater after 41 weeks when compared to a birth weight if those babies are born at term. Macrosomia is associated with obstetric risk factors to mom and baby, and the risks to the mother are maternal perineal tears, protracted labor or an abnormal labor progression, shoulder dystocia, which could affect both mom and baby, postpartum hemorrhage, instrumental deliveries, cesarean delivery, maternal anxiety, and things affecting the fetus are brachial plexus injury, neonatal clavicular function, and worst case scenario, neonatal intrapartum asphyxia. Peak placental function is reached at 36 weeks of gestation, after which diminishing rates of transfer are observed. This decline in function results in a redistribution of fetal circulation. However, the brain and the heart is spared, and it also results in a gradual reduction in amniotic fluid volume. This redistribution of fetal circulation results in decreased flow to the kidneys and the peripheries, which contributes to the development of oligohydramnios, which is the basic pathogenesis of placental insufficiency. This oligohydramnios could result in cord compression, abnormal antepartum or intrapartum fetal heart rate pattern, or the passage of meconium, which could be physiological due to the mature fetal gut or due to a pathological process which could result in hypoxia. Fetal dysmaturity syndrome describes fetuses with characteristics of chronic intrauterine malnutrition. Features of prolonged placental insufficiency or dysmaturity are babies who are born looking as though they've got a long, thin body with long nails, absence of vernix caseosa and lanuga hair, dry, cracked, or even peeling parchment-like skin, abundance of scalp hair, lichor or skin stained with meconium if it is past, loss of subcutaneous fat, especially over the thighs and buttocks, and well-developed creases on the palms and soles of the feet. Neonatal effects: acute respiratory distress syndrome secondary to meconium aspiration, birth asphyxia which could occur intrapartum or antepartum, hypoxic ischemic encephalopathy or HIE, resulting in convulsions and possible demise, hypoglycemia, polycythemia, hypothermia, and PPHN. The risk for perinatal mortality increases as pregnancy extends beyond 41 weeks of gestation. 1/3 greater risk of mortality at 41 weeks when compared to 38 weeks of gestation, with an even greater increase in the risk for IUFD at a gestation beyond 42 weeks. Most professional guidelines suggest routine induction of labor at a certain gestation of 41 to 42 weeks and 0 days, as intervention at this time reduces the perinatal mortality without increasing the perinatal morbidity. The ACOG guideline recommends induction of labor at 42 weeks and 6 days. The antepartum management at or beyond 41 weeks with a certain gestation is induction of labor is advised, and active management with cervical ripening and fetal monitoring. Should the patient further request an expectant approach, the patient should be counseled on the possible risks as previously discussed and proceed with antenatal fetal surveillance. The sweeping of the membranes is an alternative to the above and can be offered to the patient. Antepartum management at 41 to 42 weeks and beyond with an uncertain gestational age, or if an expectant approach is requested by the patient. Induction of labor is not advised, and antenatal fetal surveillance is recommended as mentioned below. The patient is to observe and record fetal movements at rest on a fetal kick chart. Antenatal fetal heart rate monitoring, a non-stress test to be performed twice weekly or CTG. Ultrasound to be used to determine the deepest vertical pool or the amniotic fluid index. If the deepest vertical pool is less than 3 centimeters or the amniotic fluid index is less than 5 centimeters, induction of labor is indicated. One is to exclude spontaneous or prolonged rupture of membrane in this case. All patients are to be advised on the warning signs and when to return to hospital, especially in the context of decreased fetal movement, the onset or symptoms of labor, or rupture of membranes. The stitch and sweep, or sweeping of the membranes, is a procedure done by inserting a finger through the endocervical os and rotating gently through 360 degrees between the membranes and lower uterine segment. This action releases endogenous prostaglandins, which may initiate labor. In 2019, a meta-analysis by Avdiivsky showed that membrane sweeping is advantageous in promoting spontaneous labor and reducing the need for formal induction of labor for post-maturity. Results of this review also showed that this effect is significant from 38 plus weeks and is independent of the number and timing of when the stitch and sweep is performed. There is no evidence supporting any increase in maternal or fetal morbidity, thereby suggesting that membrane sweeping is a safe procedure to offer to all low-risk pregnant women. The current recommendation by the NICE guidelines are that women undergo a stitch and sweep prior to the arrangement of the elective induction of labor, as in the elective induction of labor may have an impact on resources. It also has an impact on the birth experience of the woman, and each method of induction has its own respective risks. In conclusion, postpartum pregnancy is associated with fetal, maternal, and neonatal complications. Ensure accurate calculation of the gestation or the expected date of delivery. Routine induction of labor is only offered in postpartum pregnancies to decrease the perinatal morbidity and mortality, as previously mentioned, between 41 and 42 weeks. And as clinicians, we should consider offering stitch and sweep to low-risk women after 38 weeks of pregnancy. These are the references used. Thank you.